Welcome to LDI's seminar today on the maternal health system. I'm Rachel Werner. I'm the Executive Director of LDI, and it's great to have you all with us today. Among all high-income countries, the U.S. is the most dangerous country in which to give birth. We have a really great panel with us today to talk about this crisis and how we might start to fix this. It's a big topic to cover, and we have a lot to go through, so I want to just get started. So first, we have Victor Caraballo, who is Vice President of Quality Management and Chief Safety Officer at Independence Blue Cross, where he is responsible for all quality and safety activities. Dr. Caraballo also leads Independence's health equity program, which includes internal and external initiatives across many stakeholder organizations. Veronica Gillespie-Bell is an associate professor at Ochsner Health in New Orleans and serves in leadership roles throughout the health system. Dr. Gillespie is also medical director at Louisiana Perinatal Quality Collaborative and Pregnancy Associated Mortality Review for the Louisiana Department of Health. Joining us today is also Rachel Hardiman, who is an associate professor in the Division of Health Policy Management at the University of Minnesota, where she is the founding director of the Center for Anti-Racism Research and for Health Equity. Dr. Hardiman also serves on maternal health working groups at the state and at the national level. Pooja Mehta is the Women's Health Lead for City Block Health, which is a company that facilitates healthcare delivery for low-income urban populations. Prior to joining City Block, Dr. Mehta was interim chief medical officer and chief clinical innovation officer for Louisiana Medicaid. And then Karen Scott is Black feminist physician scientist, founding CEO and owner of Birthing Cultural Rigor, a quality improvement and implementation science research and practice firm that facilitates community and health system uptake of empathy, evidence, and equity-based interventions to improve care experience and outcomes of Black women, girls, and gender-expansive people. Dr. Scott also serves on several state and national research advisory boards. Today's panel will be moderated by LDI Senior Fellow Sindhu Srinivas. Dr. Srinivas is professor of OBGYN here at the University of Pennsylvania, where she is also vice chair for quality and safety and physician lead for Women's Health Service Line for Penn Medicine. She is a member of the Pennsylvania State Perinatal Quality Collaborative Advisory Committee and the Pennsylvania State Maternal Mortality Review Committee. So Sindhu, with that, I will turn it over to you, and I look forward to the conversation.
Thank you, Rachel. Good afternoon, everyone, and thanks for joining us. As Rachel mentioned, among all high-income nations, the U.S. is the most dangerous country in which to give birth. Maternal mortality is defined as the death of a person during pregnancy or within 1 year of the end of a pregnancy. The U.S. maternal mortality rate for 2020 was 23.8 per 100,000 live births. And just for comparison, in Canada in that same year, in 2020, it was 10 per 100,000 live births. In the US, when we drill down to different populations, we find really stark and unacceptable disparities. Regardless of income or education level, Black people are 3 times more likely to die from pregnancy-related complications. Native American people are twice as likely to die. And people who live in rural America, where there are many maternal care deserts, are about 60% more likely to die. And I think the other thing that it's important to sort of understand is that many of these deaths could have been prevented. A new CDC report that just came out based on data from 2017 to 2019 determined that 84% of people who died during pregnancy, delivery, or through that 1 year of an end of a pregnancy were potentially avoidable. And given all of these maternal mortality numbers, the results of a Blue Cross Blue Shield report on severe maternal morbidity are really not surprising. Adverse medical events among people giving birth increased by about 9% from 2018 to 2020 among people both with commercial and Medicaid insurance. And the rate increases were greatest for Black people and other people of color. So by all measures, we are in a maternal health crisis. And so in response to this crisis, the White House has issued a blueprint to address the maternal health crisis. And the vision is for the United States to be considered the best country in the world to have a baby. I think we, as the panelists here, and many of you all believe that this is actually very possible, but it's going to take a multi-sector, collaborative, and innovative approach. And so some broad overarching questions we hope to answer today are: what policy changes need to be made to accomplish this vision? What is actually possible? And how can we really transform our healthcare system and make it safe for people to give birth in the United States? And with that, I want to thank all these panelists that are on today again, and I will kind of look forward to this conversation that we're going to have today. And I'll sort of direct my first question to Veronica. Veronica, according to the CDC, among deaths for which timing in relation to pregnancy is known, we know about 22% of the deaths occurred during pregnancy, 25% on the day of delivery or within the first week, and more than 50% from that first week through 1 year post-delivery or end of a pregnancy. What do you think these data tell us, and how do these data kind of play out in your day-to-day practice and how you think about solutions to this crisis?
Hi, Cindy. Thank you so much for that question. We just released our 2017-2019 maternal mortality report for Louisiana as well, and we're seeing the exact same thing. The majority of pregnancy, actually the majority of all the deaths, but specifically pregnancy-related deaths are occurring from the time of delivery up to 42 days, and then another large percentage from 42 days up to 1 year. The biggest thing that I see is that we are disconnecting our moms from care. As soon as they deliver, they are disconnected until an arbitrary 6-week appointment. And then they really are disconnected from care. And so all of this to me says how we need to stay connected and keep our moms connected. Now, one of the things that we're doing in our health system is we have a telehealth program called Connected Mom. And so in this program, moms get a blood pressure cuff, they get a digital scale at the beginning of pregnancy. And so this keeps them connected in that way and able to monitor those vital signs. We also are able to do virtual visits. And so for those moms that deliver, we know, especially if they have a hypertensive disorder pregnancy, we should be checking blood pressures. And we know hypertensive disorders, cardiovascular conditions, at least in Louisiana, the leading causes of pregnancy-related deaths. And so we are able to keep the moms connected in that way. We're able to do virtual visits for mood checks, mental health disorders, as we know, also one of the leading causes of maternal death. And just really looking at ways that we can bring care to the mom instead of making mom come to the care, because there's such a barrier for a new mom to have to come into the office with their newborn child. And so just as in my day-to-day care, just seeing ways that we can stay and keep moms connected beyond the pregnancy time into a whole year following the delivery.
Thank you for that, Veronica. Rachel, maternal outcomes for Black women, as I said earlier, and as we all know, are unacceptable. What do we understand about how structural racism affects those outcomes? And what do you think are some policy, what's needed at the policy level to address some of these factors?
Thanks for that question. I think I always like to start by reminding us that we actually do have the power and the tools and the skill sets to achieve birth equity, despite sort of the what feels like the insidiousness of structural racism. It's a complex issue, but it's not one that we can't fix, right? So structural racism refers to the totality of ways in which societies are fostering racial discrimination, and that can show up in a lot of different spaces, from housing, education, employment, policing, healthcare, criminal justice. And so I think it's important for folks to understand first and foremost that what we're talking about when I refer to structural racism is something that's a fixture of the social, economic, and political systems in which we all exist, live, raise our families in, do our work in, and access healthcare in. And so there's sort of two big buckets of how I kind of like to explain the ways that structural racism is contributing to maternal and infant health outcomes. And the first is thinking about the outside environment being outside of healthcare delivery systems. So we know that the social determinants of health, so where we live, work, and play, matter for health and well-being, for our ability to thrive, raise healthy families. What's at the root of that is structural racism, right? That has dictated if someone gets to live in a healthy community, if they have access to healthy foods, if they have access to safe green spaces. It's going to impact whether or not they live in a neighborhood with dense housing or poor air or poor water quality. It's going to dictate if they're exposed to police violence or simply just being surveilled more by police, which my research has shown contributes to adverse preterm birth. And then we have to think about what's happening when birthing people are accessing a healthcare system. So our healthcare systems are not immune from structural racism, right? They have actually been built and constructed within the racial ideology of white supremacy and structural racism. And so and I would argue we have not fully grappled with what that means and how that translates to poor care and low quality care, particularly for Black and Indigenous birthing people. And so then what we see is our birthing people are accessing a system that doesn't actually, isn't rooted in the idea or the notion of them thriving, right? They're not tied to their humanity in any way. Our research has shown that for Black infants who are cared for by a white physician in the newborn hospitalization phase, that they're twice as likely to experience newborn mortality, right? Whereas when they're cared for by a Black physician during that same time frame, they're more likely to survive. And that's not about individual physicians who are, trying to harm Black infants. It's about the fact that we are working within a healthcare system that has not reckoned with the long and deep history of racism that has informed how physicians have been trained, how care is provided. And so that's why I started with the fact that we still, despite all of that, and those are just a few examples, right, of how this is all playing out. And despite that, we have a lot of tools at our disposal and within our communities to do something about it. At a policy level, and my team and I were always thinking about how do we use the research that we're creating to inform policy. And so we're thinking about what does it mean to grow and diversify the perinatal workforce? How do we get more midwives of color, more midwives from Black and Indigenous communities into the workforce to care for birthing people from racialized communities and their infants? We just heard about sort of what's happening in the postpartum period and the weeks between childbirth and that 6-week postpartum visit, as well as what's happening in that year postpartum, and thinking about how do we expand coverage and ensure that people have access to care, but not just having access, right? What we're seeing is that access isn't enough if that access isn't anti-racist, if it isn't high quality. So also when I talk about solutions, I'm grateful to be on a panel with Dr. Karen Scott, who I think is leading a lot of the solution-based work in the healthcare delivery system that we can be thinking about in this space as well. And maybe I'll pause there. Well, actually, there's one more thing I want to say, and then I'll pause. I think when I think about solutions as well, we have to be situating our solutions within the context that maternal mortality rates in the United States are bad overall. It's not, yes, they're horrible for Black and Indigenous birthing people, but they're not great for anyone else either. And so as I think about solutions and as I think about the research that is needed to generate those solutions, we have to be looking at what our comparison group should actually be and looking at, models in Finland and other places across across the globe where moms are not dying during childbirth or during pregnancy or in that year postpartum.
Thanks, Rachel. And I think you segued well into what I was going to ask Karen, which is, one goal of the Biden-Harris plan is to ensure those giving birth are heard and are decision makers in accountable systems of care. And so based on some of your work with birthing culture rigor, how can some of those goals be met? And I think that gets into some of the solutions-based work that Rachel kind of alluded to.
Yes, thank you for asking that. Thank you, Rachel, for the shout out. So at Birthing Culture Rigor, we recommend highly that you activate and amplify the power of Black mothers and birthing people as decision makers in advancing quality, equity, and accountability across 7 quality improvement pain points that we focus on. So quickly, for ethics, we believe in funding, supporting, amplifying Black women, Black people-led community initiatives that focus on activating our power, potential, passion, and promise, not our pathology of Black lives and Black livelihoods. So that means elevating existing wisdom and community solutions, highlighting community acts of resistance and resilience, not vulnerability, and using that word in its isolated form doesn't really speak to, again, what Rachel's work does is the structural vulnerability of the structures and systems of harm and oppression. For knowledge, operationalizing Black women's people's theories and naming, defining, and examining the challenges, but as well as the solutions so that we avoid mother blame. And again, we continue to interrogate structures and systems of harm and oppression. And for leadership, this may be difficult for some people, but we need to really examine the leadership's proximity to the outcome or outcomes of interest and the communities that are most impacted, and then how proximity, positionality, and power impact our abilities to be truthful, to be trusting, to be transparent, and transforming the healthcare system. For science, that means operationalizing, at least for us at at Birth and Culture Rigor, is that how do you operationalize, again, Black women's people's theories, such as obstetric racism by Dr. Donna Ann Davis, Sojourner Syndrome by the late Dr. Leith Mullins, reproductive justice by the 12 Black founding mothers of RJ, in how we name, define, examine, contextualize, historize challenges and solutions, and then how we prioritize the methods of data collection and analysis of both narratives and numbers. Both are very important so that we can illuminate the nuances, the diversity, the beauty, the complexity and power of being who we are and our humanity. And the last three, for measurement strategies, implement measurement, monitoring, and mitigation strategies. Again, the best uncovers the problem or solutions as defined for by and with Black patient community and content experts. We don't believe in incrementalism. And as Rachel was saying, we already have the solutions. We already know what works in particular communities. Why are we not investing in what's already been serving best in our respective communities? For data quality and accessibility, I think that's very important. What data sources and types are you using? And how is your data being, again, collected, analyzed, interpreted, utilized, triangulated, all those things? How is your data being distributed? How does your data reinforce existing inequities, power inequities, racism, misogynoir? How does your organization activate and amplify data sovereignty, sharing, and ownership for Black mothers and birthing people, Black birth workers, and Black women scholars? And last but not least, for community participation partnership, again, it's the A's: acknowledge, activate, affirm, and amplify community participation in partnership with equitable compensation without structural and institutional barriers, the traditional reimbursement practices. We believe these actions, as you apply them across these QI pain points, can help move us towards equity and quality and accountability that's grounded in experiences of birthing people, particularly Black birthing people. And so most importantly, we always need to examine power, right? What are the differential risks and facilitators and barriers, burdens, and benefits between the community, the funder, and any of the MCH agencies or public health agencies or QI organizations? I believe we don't address how what we are doing, right, plays out differently depending on our positionality again. So that's what we tend to focus on, is the science, ethics, leadership, knowledge, the data quality and accessibility, the measurement strategies and selection process, and then community partnership and participation, always with equitable compensation and resources. Thanks.
Thank you for that, Karen. Pooja, I'm going to turn it over to you and sort of, I think the current healthcare system, as we've heard, we're talking about the inequities, but as Rachel pointed out, as we said earlier, it's failing all birthing people. And City Block you work for is trying to address these failures at scale in a different way. Can you talk a little bit about, how this program works and what are some opportunities, and also what are some of the challenges, and how are you sort of weaving in maybe some of the things that Karen spoke about in terms of your equity sort of framework and sort of space in that space, and how is that sort of interwoven with the work you're doing at City Block?
Absolutely. It's such an honor to be able to talk about what we're doing at City Block in this particular combination of speakers. So really excited to try and break down what we're doing. City Block Health is a value-based primary care organization, so not focused just on obstetric care, prenatal care, but we take financial risk across populations. So what this means is that Medicaid or public payers come to City Block Health and entrust us with both the primary care and the financial accountability for outcomes for populations that have been historically marginalized. And within that framework, we have a really unique opportunity to weave together all of the learnings that folks here have spoken to, learnings from what we've learned from our perinatal quality collaboratives and our maternal mortality programs, what we've learned from many, many years of qualitative research that lifts up Black and Brown women's voices around what's missing in traditional fee-for-service prenatal care. And working for a value-based primary care organization means that we can accompany birthing people in moments early in the pregnancy, before pregnancy, and after pregnancy, regardless of whether that is a pregnancy that ends in a live birth. And we have to acknowledge that, not everyone who's pregnant is going to have a live birth, and that they may still have particularly intense unmet needs that will impact not just their health, but the health of their family or community. Rachel spoke with a clarity that I'm always learning from about structural racism and social determinants of health. Our mission at City Block is to change the way care is paid for so that the care that we give is not defined by the fee-for-service system that has historically failed birthing people in the US. So I'm a general OBGYN. I've worked for years in safety net settings. Why are the prenatal visits that I've traditionally provided typically 5 to 10 minutes? What about someone's life and the challenges that they're facing can possibly be met in that typical 5 to 10 minute prenatal interaction? Instead, what we're doing at City Block Health is we get literally a list of members from health plans who seem to be, based on claims data, poorly engaged in care. And just so that we are not perpetuating mother blaming here amongst ourselves, why are folks poorly engaged in care? It's because the care is impossible to get to, or there may not be a provider nearby in a community. Our first job at City Block is to outreach to that member, to that person, and find out what it is that they need, to build trust with them so that we can even have an honest conversation about that person's unmet needs. And the way that we build trust is by hiring our workforce from the communities where we serve, specifically hiring for folks with shared life experience, and then doing a lot of investment in workforce development. That first contact is not from a healthcare provider, it's from an outreach specialist or a community health worker who has been hired because they have some shared life experience with the membership that we're serving. And our community health worker intervention is then powered or enabled by a clinically integrated team, a nurse, a behavioral health specialist, an advanced practice clinician or provider. This is a primary care model, but you can hear in what I'm describing that so many of the solutions that we have talked about for years and years in the maternal health space are actually encapsulated in this very same model. Everyone here is familiar with the research that points to why doula support actually impacts a preterm birth or can prevent a C-section. Rachel has authored some of that research, and we've poured over it as we've designed our intervention at City Block. We also have the opportunity as a value-based provider to actually interview our members and co-design with our members and our community health workers. So we're lifting up those voices and perspectives as we weave together this infrastructure. And we actually don't provide prenatal care or obstetric care ourselves at all. Our goal is to actually have an intervention that lives in the community, that wraps around prenatal practices and providers, and that wraps around health systems. We know that the folks who are at greatest risk for poor outcomes, including a pregnancy-associated death, typically are struggling with behavioral health issues, substance use issues, intergenerational trauma, neighborhood deprivation, or simply financial challenges that make care, medical care, not the thing that is the priority of the day. So we've learned from our work that the first question we have to ask our members is, what is your greatest worry today? And the whole intervention grows out of that understanding and trust. I will say that as we think about how to measure the impact of our intervention, primary care doesn't stop at 60 days postpartum, but unfortunately in the US, it often also doesn't begin before 60 days postpartum. And so one of our greatest challenges at City Block Health is to provide a pregnancy-focused intervention that then bridges to primary care that's ongoing, and making sure that the unmet needs that are exposed by a pregnancy are warmly handed off to the right team to address those needs, and really leaning in postpartum and in that 60-day drop-off where somebody may feel completely abandoned has been critical. The way we do that is by bridging to community-based primary care teams. We deliver care however the member prefers it to be, whether it's virtual, in the home, or in a hub, and it's often never in a hospital or never in a traditional office. And then also using community paramedicine and other multimodal access points for folks who may have an unanticipated need and really need that care to come to them, as Veronica alluded to. I'll pause there.
Thank you, Pooja. That was a really great summary, and I think a good transition to the question I was going to ask Vic, as you sort of alluded to sort of kind of moving beyond sort of traditional payment models and really thinking about how to provide the services, the wraparound services that are needed. So, Victor, the Biden-Harris maternal health blueprint calls for increasing access to high-quality healthcare. Yet we know the severe maternal morbidity numbers are, for those insured commercially and by Medicaid, are high. How is your payer organization working to improve these outcomes? And can you comment on sort of payment models and sort of evolution or changes to payment models, and how that can sort of really hopefully catalyze an improvement in outcomes?
Thank you, Sindhu. And it's for someone who's been involved in quality and equity initiatives for my whole career, it's such an exciting time to be here at during the time when there's so much momentum in the industry towards equity. And we're doing so much at Independence and across the Blues and across all insurers that, which I have been in contact with. And for us, within the health plan, our whole strategy is centered on improving whole person equitable health. We have articulated that as our main objective of our strategy. And, we recognize health equity as a quality of care issue. And we've embarked on a number of listening strategies across our stakeholders. And we've signed on wholeheartedly to the BCBSA National Health Equity Strategy. Because it starts from within, we've also implemented extensive implicit bias and cultural humility training within our workforce. We are implementing DE&I hiring practices, making sure that we're best in class. We understand that you have to lay a strong foundation in order to combat these longstanding structural issues. So we're investing heavily into being able to collect and deploy real data across our providers and our members. We have signed on to implement the NCQA Health Equity Accreditation in all of our plans. And we're mobilizing a number of condition-specific initiatives, starting with maternity care. And we're doing this in concert with all of the Blues. And we have a number of initiatives in our plan that are designed specifically to improve maternity care, and specifically in our vulnerable populations, and those of color. We are then going to move on to behavioral health very quickly. We have colorectal cancer screening targets and a number of other chronic diseases that we're trying to find exactly what the inequities are and how we can eliminate them. Across our provider network, we're trying to encourage better real data collection among our providers and the use of that data. We are, as you had mentioned, developing pay for equity programs. The first part of that is to be able to collect meaningful data, and pay for equity programs, or any pay for performance or value-based program, can be very complicated. And the basis of all quality improvement activities is to have strong data. So it's a huge priority for us to be able to get that data and to have our partners have that data as well. We're working to eliminate race-based medicine tools across all of our network. And those are be surprised at the number of medical algorithms that embed structural racism within them. And we are working with our partners to eliminate those. We are also developing implicit bias training and cultural humility training with our providers. And we're partnering with our providers to work together on a variety of community initiatives. Now, one of the largest community initiatives we have is a program called Accelerate Health Equity, where we're working with our health system partners, the city, and a variety of other community partners to address issues of health equity. And we have a number of other initiatives around social determinants of health, addressing food, transportation, housing, and a variety of other things. Our Independence Foundation has started the Institute for Health Equity, and they are addressing maternal health and other structural issues of racism. So I think, these are just a number of things I boiled down really hard for the purposes of our discussion, but it is a major initiative for us, both within Independence and across the payer industry, to address health equity.
Thank you for that. I'm going to push on the payment model piece a little bit more and, call it Vic, you, Pooja, whoever wants to, kind of chime in. I think, value-based payment models that include bundle payments and quality metrics are really spreading rapidly. You kind of alluded to it a little bit, Vic, and I think value-based payments as a model or method for really accelerating improvements in the maternal health crisis, reducing the disparities. How are you thinking about that? I think one other piece I'll mention is, Pooja brought up sort of primary care. And I think any of us that sort of take care of pregnant patients and post-birth, I think one of the things that really concerns us is the transition post-birth, that disconnectedness, the sort of need to provide a warm handoff, not just in those first few weeks, but sort of beyond that. And the sort of intersection between primary care, while we focus on a pregnancy bundle payment, health starts well before pregnancy, and the need for these services continues well after the end of a pregnancy, whatever the outcome of that pregnancy is. And the sort of focus on just the pregnancy, I think in some ways misses the pre and the post a little bit. And so I'm curious how you're thinking about that. Pooja, I'm curious people's thoughts about that. And I invite anyone Pooja, you're in, or Victor, you're unmuted. You can go first if you want.
Yeah. So a great question. And one of the things about payment models is that they call for significant innovation, because the models, as you just pointed out, don't contemplate the connections between all those issues. 60 days after you deliver a baby, your issues don't disappear. And so, one of the things we are looking at is how can we better integrate this? And, again, goes back to our mission of whole person equitable health. We want to take the whole person into account. And just if we look at, we have a wonderful partner in maternity care, Kayaba Care, that we are working with, where they are providing a number of different services for our mothers and mothers of color and mothers who are at risk. And these are services that are not necessarily tied to specific codes or that are easy to bill for under the old-fashioned system. So we've developed a different payment model with them that's very innovative. That sort of is a hybrid between a provider and a vendor, and trying to find out ways that we can do things that and it's a very comprehensive model that addresses behavioral health, that addresses social determinants, that's provides cultural humility, and as was stated before, provided by people who reflect the community which they're serving. And in order to be able to finance these services, we have to get creative around how we can do that, because the infrastructure is not, has not been designed to reimburse these types of services.
Ed, Pooja.
Yeah, I'll just add on to that. I mean, I think the context of our public systems being historically undervalued is really important. You know, community-based care has been stripped out of the traditional reimbursement structure. And so now we're working backwards, trying to reinsert a community-based safety net for families that is not just medical care, but also behavioral health care, substance use treatment, social support, and nursing care. And so value-based payment gives us an opportunity to pay for interdisciplinary care and also, you know, team-based care. And one of the challenges is that if you look at the maternity value-based payment tests or attempts that are out there, many of them are specifically tied to the obstetric provider or the hospital, which means that the intervention is not going to live in the community where it is most needed and be the most flexible. Many of our maternity value-based payment attempts have actually risked out the folks who are most vulnerable to poor outcomes. So if you look at some of the published attempts that are out there, they're actually excluding the folks with, you know, a prior C-section or a substance use disorder or severe mental illness. And we know from all of the data that's been generated by folks here that those are actually the folks who are most vulnerable to a severe maternal morbidity or maternal mortality event. And then the last piece is really what I was speaking to before, which is that our maternity systems of care have been siloed in our health system. And now we can't solve for these problems in that same maternal health silo. Folks need care before they become pregnant, as we've said here. They need care after 60 days postpartum. And our OB provider offices don't have the bandwidth and the capacity to be doing home visiting or virtual care 6 months postpartum, which is exactly when someone may need us most. And actually, the needs may not be well matched to an OB provider. It's going to be heart disease. It's going to be follow-up for cardiomyopathy or preeclampsia, or it's going to be intensive behavioral health and social needs referral closures. So that's certainly what our learnings have been at City Block. And the other kind of opportunity with value-based payment is learning from the community-based models that are already out there. Black-led community-based models from whom we've learned a lot, Mama Toto Village or Common Sense Childbirth. There are these pockets of community knowledge and innovation that cannot be scaled to all of the families that need those services without changing the way maternal health is paid for.
I think that, you know, sort of a critical piece of this sort of solution is around payment and really thinking differently about payment, as you sort of alluded to, Victor and Pooja. And I think another piece that Rachel and Karen, I think, and others brought up is sort of the workforce and both diversifying the workforce and sort of the members of the workforce and thinking about the sort of engaging the community. And so I'm curious, Rachel, Karen, anyone that wants to chime in, sort of what are sort of some concrete steps that you think can be taken to really increase and diversify the maternal health care workforce, including the role that midwives and doulas may play, and how thinking about that and expanding that can really improve equity. Karen, you want to go first? You got.
I was waiting. Yeah. So I think we already have data that we've had data for a while that utilization of doulas and midwives improve outcomes and experiences across the sexual, reproductive, and perinatal life force or experiences. And so we have that data. The question is, why aren't those types of data utilized as key performance indicators? I'm just going to put it out there. I heard we were talking about payment, models. I think that the ways in which we're measuring quality as it relates to which payment models we would use and how we would allow, but how health plans would determine reimbursement if we actually utilize the outcomes that show that community-led, community-driven, community-grounded workforce, the strategies, the centers or experiences, the processes, if they were actually used as the key performance indicator of quality, value, and safety, then we would have to ask the health plan, why are you then incentivizing or paying? I'm just going to put it out there. It's a strong word, but the genocide of our people, like by relying exclusively on outcome measures and claims data, It reinforces a false narrative of value and safety and quality. Outcomes measures are actually an evaluation of the performance of the body, and I'm going to say the Black and brown body, in response to the quality of care that they receive, but it's also generations and centuries of harm and violence. So by only looking at the outcome, we're actually saying we're reinforcing biological determinism or inferiority. So by linking claims data to experience measures, patient-reported experience measures, or community-driven measures of safety and quality and value, and then tethering those types of measures to reimbursement, we would probably not have, I hope that we would redesign the healthcare system, because then we will look at the loss of money. We shouldn't have to put money on the price of life, but I feel like that's the one where we're gonna have to do it. So I'm pushing for redefining what safety means. Rachel's work, my work, Brittany Chambers, there's so many people's work out there where when community finds the phenomenon that's impacting them, and then we hold systems to elevating themselves towards that level of cultural, psychological, emotional, neighborhood safety, and then require health plans to use those as ways to evaluate performance and then determine reimbursement. I feel like that is one way of grounding this whole process of payment models in equity or in accountability. And, you know, I am going to push for the patient report experience measure. I would be remiss if I didn't say that, but the patient report experience measure of obstetrical racism is grounded in all the things that we keep talking about. Is the one and only that I'm aware of quality metric of humanity, kinship, and racism, all the things that our communities keep reporting out to us that gets violated. The racism gets affirmed and the kinship and the humanity gets violated or disrupted. And so the community is searching for midwives and doulas, lactation consultants, perinatal support workers. They're not searching for me as an OBGYN, they're actually avoiding me. Even patients that look like me don't even want to come to a Black OBGYN. So why then are hospitals and health plans why do we allow them to exclusively rely on outcomes data, only data, and claims data that does not even show how these hidden, I love that because Rachel talks about hidden, but the hidden narratives of CPS and law enforcement coming to labor and delivery to escort a Black man out who just wants to protect his partner, his child. Claims data do not reveal that truth, and therefore all these injustices around testimonial truth or the way knowledge gets determined or quality gets defined, that's all injustices that health plans, I'm now holding health plans accountable for. And so if we actually make the measure of success and safety defined for buying with community and invest in what communities are already doing to mitigate harm, then we can invest in workforce development and diversification and sustainability. But that's my response to that question. I think the data and the money is going to drive the uplifting of community-led solutions.
I would just jump in. That was beautifully said, Scotty. Like I 100% agree. And I would also just would add to it, you know, based on this, you know, this community model of community-driven solutions. You know, we heard Pooja mention Mama Toto Village. There's Roots Community Birth Center here in the Twin Cities where I am that's doing incredible work. And that question of sustainability, given the payment models, is always at the forefront of can they keep their doors open for another month, right? And then the workforce piece also drives that. So we know that the people and the families that are accessing that care are accessing it because they see themselves, they see their lived experience, they see their families reflected in who's caring for them in those spaces. And there's not enough, right? And so I would love to see state level, I mean, certainly federal level policy, but we also can be thinking at a state level, what does it mean to invest early and invest often in the future, right? And the future workforce. And, you know, I'm constantly sort of doing work at both ends of the spectrum of like, what do we need to be doing long-term and thinking about long-term and what needs to happen right now in this moment, right? To keep people that I love from dying. And one of those things that's sort of out here in that long-term space, and I don't like to use this like pipeline. I think this pipeline term has been very watered down and is actually very meaningless at this point. But I think about it from the lens of medical reparations. How do we put money, how can states pass policy that puts money in people and communities and people's pockets to get the education and the training that they need from early child. I mean, it starts with your early universal childhood education, right? And goes all the way through. By the time we're identifying high achieving, diverse students in undergrad, it's too late in a lot of cases, and it's not enough. I think we also have some very real opportunities at a policy level to think about how we invest in historically Black colleges, right, to develop this workforce. I'm the graduate of Xavier University, a historically Black college in New Orleans, Louisiana, that produces the most Black physicians in the country right now, or most Black students that go into medical schools across the country, right? And so we have some very, I think, tangible opportunities in this moment to decide, we're going to create something new in these institutions and support it and back it with the resources to grow and change our workforce.
Cindy, if I could make a comment,
Sure.
So I think I absolutely love Karen's comments on the need for different and better quality measures. I think one of the things health plans are always seeking is to expand and improve quality measures so that we had a comprehensive view of the system. And I think historically, the opposition to that has not come from within health plans. It has been a struggle to be able to provide transparency on that. And I think there's a reason why within Pennsylvania, patient safety reporting had to be legislated in order to get adequate patient safety reporting. And there's been a similar experience nationally, but I think as a health plan representative and quality professional, we're always looking to be able to get, particularly on the experience side. So I think it's one of the things we would love to collaborate with providers and others in the industry around how do we, and building quality measures is trickier than you think, but it does require that collaboration to be able to build evidence-based quality measures that can be implemented in payment systems. And we'd spoken about pay for value, pay for equity, and value-based. So it requires that effort, that commitment. We're on board. I'm on board. So I think Karen and I are going to talk more about it. But it's as I said, I think the historical opposition has not been on the health plan side.
And I just wanted to elevate and echo what Rachel said about workforce development. I'm also a graduate of Xavier and Meharry, two HBCUs, and had the opportunity before Congress and White House to lift that the workforce is there. The streamline for the workforce is there. We have to invest. One of the things that we've done at Ochsner, we've developed the Ochsner Xavier Institute of Health Equity and Research to try to address these questions and address these issues. And out of that, we have a workforce development program, because everybody that attends Xavier doesn't want to be a physician, but there are other avenues in medicine where we can create those streamlines. And so we have established a physician assistance program to try to help with the diversity on that level of APRNs or APPs. And so definitely, just again, to echo what Rachel said, we have everything here. We just have to connect the dots.
Yes, Cindy, if I could also just add to Veronica and Rachel's comments. I think I also agree. There are only so many people of color in the workforce, and we need to grow that inventory so that there's more people serving communities. I am a product myself of a program, as a biomedical pre-medical high school program in New York that was designed to increase the number of minority physicians. And we simply have to train more people in the workforce who reflect those communities.
And to your point, Vic, it has to start really at elementary school. I I'm from Meridian, Mississippi. And the only reason I even knew about Xavier is because they wrote me and said, hey, we have a program and we are #1 in producing, getting Black students into medical school. And they did that reach out through my high school. And I honestly don't know that I would have known about Xavier. So we've got to do that outreach way before med school, way before college with our elementary schools.
May I add to this too? Yes, I also, and I'm going to get it from my physician colleagues, I just need to say publicly, becoming a physician is not the only way to make a difference in maternal or reproductive perinatal health. And I'm speaking specifically to Black women right now and femmes. Seeing the path towards OBGYN as a solution is problematic. Please learn the history of who we are and what the relationship was between OBGYNs and plantation and slave owners. And I'm not saying that to just be problematic. I'm just saying that there are so many other ways for us to do this work together, and actually joining the problem may not be the best way. And thinking that, oh, I'm going to get in trouble. Thinking that you are the magical Negro is not going to help us either. And I get to say that, and I'll take blame for that because I work for myself. But we have to think that we need people in policy, in quality, in data science, in health services research. We need lactation consultants. Like, the workforce does not have to be physicians and nurses only. We need all of us, dietitians, mental health professionals. And so I just needed to say that. And I'm not saying not to become a physician. I'm just saying consider the fact that we need all of us from different skill sets and experiences, and don't give up if medicine didn't work out, because there's such a rich and diverse other ways to support all of us in this space. So I just need to say that.
Thank you for that, Karen. And I'll kind of segue into a comment or a question that's in the chat that I was going to bring up when we think about sort of different opportunities or avenues to be working in this reproductive justice space. One of the action items in that Biden-Harris plan is around increasing access to midwifery and nursing care. And so curious how people are thinking about kind of improving access to and the training of midwives, particularly in diverse communities. Pooja, go ahead.
I was like, I unmuted. I think one of the greatest learnings that we've had on this value-based payment journey is that obviously we have historically gutted the midwifery workforce in this country intentionally. And by we, I'm saying my OBGYN, we, like our medical industrial complex. And now, of course, we're left with the maternity care deserts that you mentioned at the beginning of the call, Sindhu. I had the opportunity to train alongside midwives during my OBGYN residency training, and it sort of gave me this very clear and concrete vision of what a right-sized perinatal system looks like. And now in the value-based payment world, we have folks pointing to birth centers and midwifery care as solutions. I want to caution us from thinking about those as solutions simply because they're lower cost. We want to invest in those solutions. We want those midwives to be paid fairly, to have sustainable work-life balance, to have succession planning in the institutions that they're in, and really for the payment policy to reflect that this is not just equivalent care to obstetric care, but actually more appropriate for a huge portion of the population. Just by way of example, in our pregnancy care work at City Block, we have many outreach specialists and community health workers who are in the perinatal space, and their career aspiration is to be a midwife or to be a nurse. And I think it's part of the responsibility of these programs to think about how we support those aspirations for folks who want to serve the community that they grew up in. Are we really making this possible and sustainable, and not systematically discriminating against the community-based freestanding birth center? And this is one of the biggest differences between the US system and systems in Europe that other folks have mentioned on this call.
And I think somebody else sort of alluded to that earlier, the sort of learning from other countries that have a completely different sort of how maternity care is structured and in places with much better outcomes than we have, and thinking about sort of some of the learnings from that. And I think this is definitely kind of an important one. So as we sort of come to our last few minutes, Karen, go ahead, and then I'll.
Yeah, I just wanted, again, in recognizing the healthcare hierarchy for those of us who are OBGYNs, imagine what it would look like if we utilize our license to help midwives in states that have restricted access or cannot function independently. I am, same as Pooja, my chair of my OBGYN resident training program was the MD collaborator for one of the largest midwifery programs in the West Side of Chicago. And so I currently use my license to help Village of Healing to support them really in Cleveland with Dana Langford as the midwife leading that center. Is like, there are ways for us to help with reconciling the harm that OBGYNs did to midwives, particularly Black midwives. So I'm just saying there are ways for us to use our power in this hierarchy to amplify, to help with sustainability, implementation of midwifery-led models of care. And I just want to say that because I think OBGYNs don't sometimes know tangible actions they can do to reconcile the harm that our specialty did to midwifery. Thanks.
Thank you for that, Karen. And I think as we kind of are in the last couple of minutes here, I want to go rapid fire. We've talked about a lot of different things today, from payment to workforce to all sorts of, anti-racist culture, expanding the workforce, thinking about how to engage the community. When we think about sort of policy levers and sort of federal or state, if you had 5 minutes with the state or federal or U.S. legislature, state or federal, what would you identify as a must do to move the needle and improve maternal health care? And I know it's sort of unfair to say you have like 30 seconds each to answer that. And it doesn't have to be like, this is the only thing that you would say, but what is like sort of something that comes to your mind as a must do? I'm looking for who's going to unmute. Who wants to go first?
I'll go. This is not necessarily a federal, and it's definitely is also piggybacking on what has been said. I think it is great that a lot of states, Louisiana was the first that extended Medicaid to 1 year postpartum, and I advocated for that. I think it's great. But I think we have to also understand that having insurance does not mean access. And so I think definitely more needs to be done to understand what are those barriers to actually accessing care. I know there are plenty of providers that they will see you for OB Medicaid care, but they will not see you for GYN. So more research into understand that, more investment into different models of care. If it were up to me, and this is from work I've done in Australia, every pregnant individual would have a risk assessment at the beginning of pregnancy. And if they stratified to low risk, they would be offered care with a midwife. They know it is practicing above my license to need to have to see for patients to see me when they are low risk. And there are not enough obstetricians. But to do that, we've got to have investments in midwifery programs. We need investment in midwifery schools, and we need better reimbursement for midwives.
Rachel?
I'm going to go big and then go home and just say reparations.
Victor?
So I think it's hard to follow that one, but and wonderful comments, and thank you to all my fellow panelists. But I would say if I had a few minutes with our legislators, I think in a bullet fashion, we need to be able to enable better access or better ability to collect data, real data without some of the regulatory restrictions that have been on it historically. And, as a plan that provides government-sponsored healthcare plans, I think the ability to be more flexible with our benefits, so we could deploy them, a little bit more discreetly, and having the ability to have reimbursement for all of that would be also helpful. Many other things, but I will cede to my fellow panelists.
I think it's my turn. I think we need a lot more accountability around quality and reimbursement levels in Medicaid, number one. And number two, another kind of go big or go home moment. Abortion access is not the solution to the maternal mortality crisis, but it is certainly not getting us anywhere to think that we can talk about fixing the maternal health system without giving people a full menu of choices and options that are safe and high quality when they become pregnant.
I agree with everyone. I am going to say reparations, and I'm agreeing with Pooja too. Abortion is, or family planning, contraception is not the solution, which was announced at ACOG 2018 meeting. You know who said it. Third, I would say mandate racism as an adverse event. Like, health plans need to name it as an adverse event, name it as a violation of patient safety, and have the definitions of value and quality and safety be defined by the community in addition to these systems or structures. We can't repair what those in power get to dictate.
And then believe birthing people when they say that's what happened to them.
Yes.
Well, thank you all. And I think, Pooja, I'm glad you brought up abortion. We didn't really get into the impact of the Dobbs decision on sort of maternal health and all these outcomes, but it's certainly, I think, top of mind for all of us as well. And so I think we covered a lot and unfortunately didn't get to that, but lots of other things that we didn't get to as well. And we know we will continue to be thinking about that intersection, but I wanted to thank you all again, and I'll turn it over to Rachel.
Well, I will just echo Cinda's thank you. This was really an incredible conversation, and I'm so appreciative of the hour that you all spent with us having that conversation, and also of the incredible work that you all do. Thank you also to the large audience that joined us today. We are continuing this panel discussion series on a different topic next month. So please join us then, November 11th, right after the midterm elections, to have a postmortem on what those elections mean for healthcare policy. Until then, we hope you all stay safe and be well.